Thank you, Doctor. It's my pleasure to be always with this conference. Congratulations to Dr. Abdul Malki for this great effort. And as I said yesterday, we definitely need to generate more data from our local society. Now, this is a very debatable issue, and I'll see where the discussion can take us to, whether you will agree or disagree with me, we'll see. So this is a hot area. I'm assuming it's hot, but my objectives is to address gaps in issues related to musculoskeletal examination. This is my favorite research topic and my favorite point to address always in conferences and in my teaching and my talks, to discuss the added value of musculoskeletal imaging in early diagnosis of arthritis, and to review the findings of musculoskeletal imaging in normal people and in rheumatoid arthritis patients on remission. I won't talking about remission because I don't think I'll be having time. I can mention a few things if there is time allowed. To assess the value of incorporating musculoskeletal imaging in daily clinical practice. Okay, these are my major objectives. And immediately, I will ask you a few things, and you can vote if you like. What do you think? Is musculoskeletal imaging should replace musculoskeletal examination in daily clinical practice? Hands up if you agree. You should replace it. One would agree. Okay, thank you. Do you think musculoskeletal imaging should predominate, particularly ultrasound, in daily clinical practice? Would you agree? Okay, 3, 4. Musculoskeletal examination still should be the cornerstone of daily clinical practice. Hands on. Okay, good. Alhamdulillah. We'll have 2 hands together. Okay, good. Musculoskeletal imaging and musculoskeletal examination are complementing each other in daily clinical practice. Okay. طيب, شكرا دكتور أسامة. We'll see. So before I go to the depth of the discussion, I'll tell you immediately my last slide at the beginning and the take-home messages. Musculoskeletal examination is way underutilized in day-to-day practice, particularly for non-rheumatologists. So this is well known throughout different studies from different parts of the world. I won't go into the details of that, but it is documented for over 2 or 3 decades. Musculoskeletal exam lacks standardization and proper validation. And this is true even for imaging. And I will show you data. Imaging can help in early diagnosis. There's clear evidence about it with some background noise. I will mention it also during the talk. But at least imaging can help in early diagnosis of inflammatory arthritis and rheumatoid arthritis. There is no evidence. This is my conclusion, but I'll show you also the discussion around it. There is no evidence to support added value of imaging in adjustments of treatment decisions, prediction of remission, and prediction of workability. Zero evidence or no good evidence to support the use of imaging in these options. Okay. And imaging musculoskeletal exam, I believe, should complement each other. And I'll tell you a few examples in my practice that I really used imaging heavily to help me in diagnosing my patient. So the outline is 3 things: why musculoskeletal examination is still essential, imaging in early diagnosis, and the role of musculoskeletal imaging in monitoring disease activity. These are the 3 major outlines. Let's talk about musculoskeletal examination. Just read the title, Back to the Future, Forget Ultrasound and Focus on Clinical Assessment. This was published in Annals of Rheumatic Disease recently, or 2017. So some issues, I just want you to think about it while I'm talking. Musculoskeletal exam is still a cost-effective method. As physical exam, we are clinicians. We are not lab technicians. We are not lab specialists. We are not radiologists. We are clinicians. Clinicians should take history and physical exam for not only rheumatological diseases, for any disease in medicine. So still has its value, but again, it lacks standardization, same as in particularly ultrasound. Majority of patients, there are efforts, I know, those believers of ultrasound, but still there are some gaps in our knowledge about standardization in ultrasound and imaging in general. Majority of patients with rheumatic diseases are seeing non-rheumatologists by evidence. In our population cohort of rheumatoid arthritis that we published a few years ago, up to 80% of our RA patients will see orthopedic surgeon first. So, and we'll see in other parts of the world, we'll see primary care physicians. So they are not seeing us primarily. So are they going to do ultrasound for you to diagnose patients or to? Okay, think of the broad spectrum of musculoskeletal disorders, including soft tissue rheumatism, which is far more common than inflammatory arthritis. So do you still want to see in your practice lateral epicondylitis instead of these cases being diagnosed by primary care physicians or general internists? You want to diagnose rotator cuff tendinitis in your practice? We are trained. We should diagnose them, but why they should take the spot of a patient with lupus? Why should they take a spot of a patient with active rheumatoid arthritis? These simple disorders can be diagnosed by their primary care physicians. So I still, until now, of over 20 years of practice, I have patients with decurrence tenosynovitis, lateral epicondylitis in my clinic, I'll see lupus nephritis before them, then I'll see active RA after them. Why do I need to see that? Anyway, can general practitioners perform ultrasound in every patient? For sure not. There is another legal issue. Training rheumatologists in imaging, what is the cost of that? What is the clinical time? What is the certifications? Do you think our colleague radiologists will give us, they will be happy for us reading ultrasound and doing ultrasound for ourselves? Okay, and authorities, are they going to give us license to read ultrasound? Anyway, there were just issues to think. Musculoskeletal medicine, is it adequately addressed in undergrad and postgrad curriculum? Bring residents who just finished rheumatology rotation in any one of our centers. Are they competent in performing physical exam? We can keep asking these questions. I don't think they are competent because in general, there are good centers anyway, but in undergrad, how is the teaching of rheumatology in undergrad curriculum? All over the world, is it really properly presented as we are presenting cardiovascular diseases? Is musculoskeletal exam properly taught? But the focus, is it on trauma? Our colleagues orthopedic, they keep teaching things and they keep taking the picture or the highlights or the view of musculoskeletal medicine from us because they are focusing on trauma, traumatic things. And I understand why, because road traffic accidents is a major killer in our societies. But what about arthritis? Are they able to teach patients, students and residents how to diagnose patients with arthritis? Do we need update on a classical approach to musculoskeletal exam, like look, feel, and move? I think we have to. Look at this. I took this from one of randomized control trials. The primary measure of pain or at joint level was obtained from the 68 tender joint count that was assessed by a trained research nurse at baseline. You will see this consistently across many randomized trials in arthritis and rheumatoid arthritis. But only one person was doing the assessment. On what basis? What guidelines? What protocol? What system did they use to examine the joints? It's vague. This is what I'm mentioning about standardization. There's no standardization. They said they will distribute booklets how to examine the joints. Every study will have its own booklet of physical exam of the joints. And it was also listed in the literature. But limitations in physical exam, exactly like limitations in ultrasound. Fibromyalgia patients, obese patients, reliability, operator dependency. Okay, so same limitation. So why should the physical exam be underestimated comparison to ultrasound? Well, both have the same kind of limitations. Okay, we did screening of the musculoskeletal skills among internal medicine residents years ago, and it was really deficient. I did write about the approach of physical exam that should be focused on one approach, and this is the approach that we wrote about it in our textbook in Skills in Medicine, and I published this, and I teach this, and I advocate all of you to use that, not because I did it, no, wallahi, read it and see. If you are convinced, please follow this approach. Inspection, screening, palpation, range of motion, special test, and we did standardize the physical exam of the hand, and we validated this. And we wrote distinctive description of how to perform the physical exam of the hand, and we validated this by ultrasound. And we showed real up to 70% sensitivity to detect arthritis if we did the technique correctly. Not all that, but also we published this with the American Association of Medical Colleges, the techniques that we have done, and in my book, recently published, Skills in Rheumatology by Springer. And we use these basic things, basic skills in hand examination to determine referral criteria in a project conducted by Ministry of Health with their help. And actually, the level of skills by primary care physicians is almost not high correlation, but moderate to low correlation with the rheumatologist. So if you train your primary care physicians properly to do the exam, they will pick up for you arthritis. Okay, so this is enough said about musculoskeletal examination. Let's talk about imaging and early diagnosis of RA. Early diagnosis, remember, early diagnosis and monitoring of disease activity. Early diagnosis, this is an excellent review published 2017. It's concluded that musculoskeletal imaging has a useful role in detecting progression of inflammatory arthritis to rheumatoid arthritis, possibly from arthralgia to inflammatory arthritis. This is just the table that they published. I will not go into the quality of the studies. I will not go on the issues like related to presence of control group. We'll just take it, there is evidence. I agree with them. There is, if you talk a group of population patients with early symptoms and you follow them up based on certain parameters on ultrasound, you can predict the progression to inflammatory arthritis. Okay, that's fine. But look at this. The evidence would be better if it was added to the clinical assessment. This was also another study. So if you add bedside assessment to your ultrasound, you will improve your ability to diagnose arthritis early. There is certain predictors of progression to arthritis, presence of baseline pore Doppler positivity, odds ratio 117 in another study, which again, excellent point. I'm not saying, I'm open, but I'm just presenting to you. The bottom line is the value of musculoskeletal exam that we have to go back to the bedside as the first article I showed you. But I'm just making things on the right track because some of us are really huge believers on ultrasound and MRI while they are forgetting the basic bedside skills and manners that they should really be utilizing more and more. Even for MRI, bone marrow edema preceded bone erosions in several studies. I'm not arguing that. It's very well documented. But are you going to do early MRI on every single patient with joint pain? No. So bone marrow edema also was associated with erosive progression of diseases. Okay, so early diagnosis, good. But there are, again, clinical value, bedside exam is essential if you add it to ultrasound. Aqua positivity, definitely higher score for osteitis. So if you have patients with aqua positive and you did MRI, they will have higher chance of progression to arthritis. Even MRI tenosynovitis, which there is new now definitions that they should refresh the definition of arthritis based on ultrasound, based on MRI, by adding tenosynovitis to the definition of that. I'm not an expert in MRI, I'm not an expert in ultrasound, but I'm telling you this is what they are talking about. The background noise. Even having said that it's important in early diagnosis, there are negative studies. Okay, there are studies clearly stating that musculoskeletal ultrasound should not be used as a screening tool, not like it was some of us are doing in their clinics. New patients will have their ultrasound first, and then will come and see you. And you stop being, you will be lazy just to look at the ultrasound findings and do. Is that good clinical practice? No, it's not a good clinical practice. Why? Only 30% in this cohort progressed to rheumatoid arthritis in a seropositive. Seropositive, 30% of them progressed. And borrowed Doppler was present in only 4%. So it's not predominant findings in these patients. Systematic review about all the studies published 2018, limited ability of ultrasound to predict inflammatory arthritis. Limited to moderate. I mean, the predicting ability to inflammatory arthritis based on systematic review was, it's not high. So part of the background noise in the literature, standardization is an issue. There is, I know, huge group of researchers working on specific standardization, but what method, how many joints are going to scan? What methodology are you going to use? Many issues about, and inter-reader reliability. These studies on MRI particularly was done among experts, radiologists who can read MRI carefully. What about real life practice? I came across radiologists who are not interpreting MRI, musculoskeletal MRI properly. And I had to have another musculoskeletal radiologist reading their findings. These are radiologists, okay? So this is again an issue here. As I said, number of joints to be scanned. Where should we draw the line between to define a truly abnormal ultrasound score? Even if you have a score, what is abnormal, what is normal? The cost, definitely, availability, variabilities of RA disease activities in different studies. So there is a study done on RA on remission, another study done on RA while they are on treatment, other done on RA, early RA. So RA is not one disease, okay? So what kind of RA patients included in your study? So this is, again, one of the variables that may affect the outcome of almost all imaging studies. Findings in normal individuals. Okay, you'll be surprised. Again, look at this study. Normal individuals, up to 70, only 28 had no inflammatory features, 70%. This is published in Arthritis and Rheumatism 2016. Almost 75% of patients will have abnormal findings by MRI. Okay? And this level increases with age. Another thing, erosions score above more than 0 present in up to 30% of patients with normal. They don't have any complaints. So is this enough background noise for you or not? For me, it's enough. So, okay, so we finished from early diagnosis. Overall, you can use it. I'm not saying no. With the presence of joint symptoms and presence of aqua positivity. In monitoring disease activity, this is published, mentioned yesterday by 2 days ago by Professor Chan, TASER study. A 2 group of patients, intervention group based on ultrasound and control group based on conventional DAS-driven strategy, and no difference. Not significantly different better terms in of outcome, whether you use ultrasound to guide your therapy or use standard approach. Another group, open label trial, again, ultrasound-based group, conventional strategy group, no difference. Very similar outcomes, okay? And use of ultrasound in monitoring this activity is not justified. The same group, 2020, published based on MRI, no difference. This landmark study in JAMA, same thing, 200 RA patients, MRI-based therapy, treat-to-target approach to conventional approach, no difference. But why I brought this one? MRI group, look at this number. 46 patients who used MRI, sorry, I cannot do this. 46 patients who used MRI as a base on their decision making had more biologics prescribed comparison to only 2% where they used their clinical judgment. Was that for added value? No. No added value. What was the drawback? More cost, more side effects for those who are a believer in MRI monitoring disease activity or even ultrasound. So I won't go into reasons because of the lack of time. Even prediction of remission. Same, look at numbers, same thing could be done for DAS and for ultrasound to predict remission. So why should I use then ultrasound to tell me if this patient is going to be in remission, if I can reliably, based on this study, if I can use basic bedside skills to determine if this patient is going to be in remission or not. And this was work that we did publish, part of our registry. I won't go into the details of the study, but what we found, ultrasound did not predict workability. The one that would predict workability was fatigue score and hack score. So ultrasound for us in the clinic for workability, which is more meaningful for our patients, was not that of great value. So back to my take-home messages, ladies and gentlemen, chairpersons, ladies and gentlemen. Musculoskeletal exam is way underutilized too in our day-to-day practice. Musculoskeletal exam lacks standardization, like in also some imaging modalities. Imaging can help in early diagnosis. There is no evidence to support use of imaging in treatment decisions or prediction of remission or prediction for workability. Even it may let you prescribe more biologics. It may cost you more without added value, as I did show it to you. Imaging musculoskeletal exam should complement each other. The exam that I want to tell you, I had 2 patients who were not responding. I did MRI. They had pigmented villonodular synovitis in their small joints. These 2 in my 20 years of practice. So sometimes I use imaging MRI if my patient is not responding despite many interventions. And I was banned one time because it's rare for pigmented villonodular synovitis to be in the small joints. I had 1 case. Another time, patients in her knees, she didn't respond to injection. I actually inherited her from another colleague. She was on methotrexate for 6 months. MRI was synovial thickening. We did biopsy, pigmented villonodular synovitis. She was young. So you can use MRI to to evaluate patients who is not responding, you have a question mark on the diagnosis based on the clinical follow-up. Thank you very much.